failing heart back from the brink. And our mission today is to unpack the actual biological mechanics behind how it works.
Yeah, and it really functions as a survival map for these patients. When you look at how this sheet approaches the failing heart, it immediately establishes a very strict philosophy.
Okay, what do you mean by strict?
Well, before any therapy is even initiated, the clinician absolutely must answer 3 foundational questions. First, is this definitively heart failure? Second, what is the specific ejection fraction? And third, which is crucial, what is the underlying cause?
That third question really stood out to me. The sheet explicitly labels this a golden pearl, stating that a heart failure diagnosis is essentially invalid, or at least incomplete, until you find that root cause. Why the absolute insistence on that?
Because, simply put, heart failure is not a primary disease.
Oh, interesting.
Right, it's a secondary syndrome. It's the mechanical consequence of some upstream insult. If a doctor just, aggressively treats the fluid overload and the weak pump without hunting down the trigger, well, the patient will inevitably crash again.
Right, because the fire is still burning in the background.
Exactly. And the sheet uses the mnemonic failure to categorize these reversible triggers. It forces the doctor to look beyond just the heart muscle.
Yeah, and looking at that list, you have things like ischemia, uncontrolled hypertension, fast arrhythmias, which logically makes sense, right? They directly damage or exhaust the heart. But then it includes anemia and endocrine disorders, specifically thyroid issues.
Yeah, those can be surprising.
They really are. Let's dig into the mechanism there. How does a purely hematological issue like anemia literally break the heart pump?
It all comes down to cellular oxygen demand versus delivery. In severe anemia, your blood's oxygen carrying capacity just plummets.
Because you don't have the red blood cells.
Right. So to keep the brain and vital organs oxygenated, the heart has to dramatically increase its cardiac output. It starts beating faster and harder continuously.
Wow, yeah.
And this creates a state of high output cardiac failure. The heart is essentially sprinting a marathon 24/7 to compensate for the thin blood. Eventually, the myocardium just exhausts itself and dilates.
So if you don't fix the anemia, no amount of heart medication is going to save that patient.
Not long term, no. You have to fix the supply line before you try to rebuild the pump.
That reframes the entire approach. Okay, so once they identify that cause, they stratify the patient. We see the classic ejection fraction categories on the sheet: HFR-EF under 40%, HFMR-EF in the 40s, and HHP-EF above 50.
Yes, the EF is fundamental.
But alongside those numbers, the sheet makes this very rigid distinction between HEA stages and NYHA classes.
Which is vital because blurring the lines between those two frameworks is a really common clinical pitfall. They measure entirely different dimensions of the disease.
I've heard this car analogy used to a brilliant effect here to explain it to patients. Have you heard that one?
I think so, but break it down for the listener.
So the HEHA stages, which progress from A to D, are described as the physical, irreversible wear and tear on the car's chassis. It's the objective structural remodeling of the heart. Once the left ventricle dilates and scars, the frame is bent. It doesn't regress back to stage A.
Right, the structural damage is locked in.
Exactly. But the NYHA class, which uses Roman numerals I through 4V, is simply how the car is actually driving on the road today.
I utilize that exact framework. It's perfect. The NYHA class is purely functional and symptom-driven. Like a patient in class 4 is highly symptomatic at rest. They are struggling for breath just sitting in a chair.
But unlike the structural stage, that NYHA class is dynamic.
Very dynamic. With aggressive guideline-directed medical therapy, you can take a patient whose heart structure is permanently stuck in stage C, but physiologically reverse their symptoms from a class 4 all the way back to a class I.
Where they're essentially asymptomatic in daily life. That's incredible. And that dynamic shift in functional class brings us to the physical bedside examination. Because if NYHA classes are dictated by symptoms, the physical exam is about tracing the fluid dynamics of the backup, right?
Precisely. When the left ventricle fails to pump forward efficiently, the end diastolic pressure rises, and that pressure transmits backward.
Right into the pulmonary vasculature, which gives you the classic orthopnea and the crackles you hear on a stethoscope.
Exactly.
But the sheet also highlights specific signs like a raised jugular venous pressure, or JVP, and positive hepatojugular reflex. So we're looking at right-sided backup here too.
We are. The fluid backs up from the left heart into the lungs and eventually strains the right heart, which then transmits that pressure down into the venous system.
Oh, so that's why you see the JVP rise.
Yes, the internal jugular vein is basically acting as a direct manometer for the right atrium. And with hepatojugular reflex, when you apply sustained pressure to the liver, you are physically displacing congested venous blood upward.
Just pushing the fluid up the pipe.
Exactly. In a healthy heart, the right ventricle easily accommodates that extra preload, but in a failing heart, it can't. And you literally see the neck veins bulge in real time.
It's mechanical plumbing at its most raw. But bedside signs are only one piece of the puzzle. The sheet moves heavily into the lab values next. And this is where we hit the BNP paradox.
Ah, yes. The natriuretic peptides.
Right. The cutoffs are very specific here. BNP under 100 or NT-proBNP under 300. The exam pearl on the sheet states that a low BNP is vastly more clinically useful than a high BNP.
It absolutely is.
It operates exactly like a strict bouncer at a nightclub, doesn't it?
Expand on that for a second.
Well, think about it. If the bouncer checks the list and your name isn't there, meaning your BNP is below 100, you are definitively not getting into the club.
Right.
The negative predictive value is massive. The patient does not have acute heart failure. But if your BNP is 800 and the bouncer lets you in, It doesn't mean you're a VIP heart failure patient. You could be in the club for a dozen other reasons.
That is a phenomenal clinical heuristic. A high BNP simply indicates myocardial wall stress.
Yeah.
The ventricles are stretching and releasing the peptide.
So it's not specific just to heart failure.
Not at all. The sheet meticulously lists conditions that cause false positives. Chronic kidney disease, pulmonary hypertension, sepsis, atrial fibrillation, any of those can stretch the heart or prevent the kidneys from clearing the peptide out of the blood.
Wow, okay. But the false negatives are what really caught my eye. How does severe obesity actively suppress BNP levels, even in the presence of florid heart failure?
It's a fascinating mechanism of clearance. Adipose tissue, or fat cells, have a high concentration of clearance receptors specifically for natriuretic peptides.
Right, really?
Yeah, the fat cells literally vacuum the BNP out of the bloodstream faster than the failing heart can produce it.
Oh, wow.
So a morbidly obese patient might present in severe cardiogenic pulmonary edema, struggling to breathe, yet their BNP comes back in a seemingly normal range. If the clinician doesn't understand that physiological masking, they completely misdiagnose the patient.
That is wild, which is why the algorithm dictates that the ultimate arbiter, the real cornerstone for every newly diagnosed patient, isn't the lab test at all. It's the echocardiogram.
Always the echo.
You have to visually map the structural geometry, measure the chamber volumes, and definitively calculate that ejection fraction.
Right, the echo removes the ambiguity. Once you have that EF, particularly if it's HFR-EF, which is under 40%, the treatment pathway completely diverges into the modern pharmacological era.
And this era is incredibly aggressive. The sheet refers to the Fantastic Four: ARNIs, beta blockers, MRAs, and SGLT2 inhibitors.
The foundational pillars.
Right. And historically, clinicians used a stepped approach, right? Like start an ACE inhibitor, wait a month, maybe add a beta blocker, titrate slowly. But the new guideline principle explicitly demands establishing all four foundational pillars rapidly within 2 to 4 weeks.
The paradigm totally shifted. We realized that the longer you leave the neurohormonal pathways unopposed, the more irreversible scarring occurs in the myocardium. You have to shut down all those maladaptive stress responses simultaneously.
Okay, let's break down the mechanics of those specific drugs because the rules of engagement here are intense. Take the ARNI, sacubitril/valsartan. The board exam favorite is the strict 36-hour washout period if you are transitioning a patient from an ACE inhibitor to an ARNI.
Yes, you absolutely cannot overlap them.
I understand we're avoiding angioedema, but what is the actual cellular mechanism there? Why does the face and airways suddenly swell up if you mess that up?
It's all about a peptide called bradykinin. Bradykinin causes profound vasodilation and vascular permeability. It essentially makes your blood vessels leaky.
Okay.
Now, ACE inhibitors naturally increase bradykinin levels. Sacubitril, which is the active component of an ARNI, blocks an enzyme called neprilysin. And neprilysin is also responsible for breaking down bradykinin.
Oh, I see where this is going.
Right. So if you overlap the two drugs without that 36-hour washout, you hit the bradykinin degradation pathway from two sides simultaneously. Bradykinin levels just skyrocket. The vessels in the deep dermis and submucosa leak massive amounts of fluid, and the patient's airway swells shut.
That is terrifying. Yeah. But the physiology perfectly explains the protocol. So now let's look at the beta blockers, specifically bisoprolol, carvedilol, and metoprolol succinate. I need to push back on this concept for a second. Go for it. If a patient's heart is already failing, right, it has a severely reduced ejection fraction. Why on earth are we giving them a drug class fundamentally designed to slow the heart rate and reduce contractile force? Isn't dropping cardiac output in a failing pump inherently dangerous?
It seems entirely counterintuitive, which is exactly why beta blockers were historically contraindicated in heart failure.
Right.
Acutely, yes, they are negative inotropes. They weaken the squeeze. That is why the sheet emphasizes the golden rule: never initiate a beta blocker if the patient is in acute decompensation shock or severe volume overload.
They have to be stable and euvolemic first.
Correct. But chronically, heart failure triggers a massive, unrelenting surge of the sympathetic nervous system. Adrenaline and noradrenaline just whipping the tired heart to beat faster.
Like flogging a tired horse.
Exactly. Over months, that constant sympathetic stimulation is intensely toxic to the heart muscle cells. It causes them to undergo apoptosis, or cell death. By carefully introducing a beta blocker in a stable patient, you shield the myocardium from that toxic adrenaline bath.
Oh, okay.
The heart slows down, the diastolic filling time increases, and over several months, the ejection fraction actually improves.
So you are sacrificing a tiny bit of acute output to prevent long-term cellular destruction. That makes total sense. Following that same logic of blocking maladaptive pathways, we have the MRAs, like spironolactone and eplerin.
Right, the aldosterone antagonists.
They block aldosterone, which stops the kidneys from retaining sodium and water, but they also directly prevent myocardial fibrosis.
And that antifibrotic effect is crucial for remodeling. But you have to monitor the metabolic side effects closely. Spironolactone binds to androgen and progesterone receptors, which is why it commonly causes gynecomastia or breast tissue growth in men.
Which obviously causes compliance issues.
Absolutely. So switching to eplerin circumvents that because it's vastly more selective for the mineralocorticoid receptor. It avoids the endocrine toxicity.
Makes sense. Then we have the final pillar, which has arguably changed cardiology the most in recent years. The SGLT2 inhibitors like dapagliflozin.
The miracle drugs.
Right. Originally diabetes drugs, and now they're heart failure saviors. The sheet notes a really specific phenomenon, though. A transient mild rise in creatinine when you start the drug. For a clinician, seeing kidney function technically worsen on a lab test usually triggers panic. Why does the sheet insist this is not a reason to stop therapy?
Because it's a hemodynamic illusion of harm that actually represents long-term protection.
An illusion, how so?
SGLT2 inhibitors cause constriction of the efferent arteriole in the glomerulus. Basically, the outflow pipe of the kidney filter. They essentially lower the interglomerular pressure.
Okay, reducing the pressure in the filter itself.
Yeah, exactly. That drop in pressure slightly reduces the overall filtration rate, which bumps up the creatinine in the blood temporarily. But by lowering that high pressure state, you are actively protecting the delicate nephrons from burning out over years of strain.
It's relieving the mechanical stress on the renal filters. That's brilliant. Now, comparing these Fantastic Four to classic diuretics like furosemide reveals a really stark contrast.
It really does.
Because diuretics are incredibly effective at clearing pulmonary edema and making the patient feel like they can breathe again. Yet the data is unequivocal. They do absolutely nothing to improve mortality.
That is the cruel irony of heart failure management. If you conceptualize the failing heart as a boat taking on water through a shattered hull, furosemide is simply the bucket.
Just bailing water.
Right. It rapidly bails the water out, preventing the patient from drowning in their own fluid today. It resolves the symptoms instantly, but the bucket does nothing to repair the hull.
Ah, I love that analogy.
The Fantastic Four, by blocking the RAAS pathway, the sympathetic nervous system, and altering cellular energetics, those are the tools that actually patch the fiberglass and rebuild the engine.
Bailing water versus patching the hull. That perfectly delineates symptom control versus disease modification. But, this entire protocol assumes a classic HFrEF presentation. The sheet also dives into the hidden metabolic deficits that sabotage recovery, specifically iron deficiency.
Which is incredibly common in these patients.
And the diagnostic thresholds are uniquely aggressive here. Ferritin under 100 or a TSA under 20%. But the therapeutic mandate is what really stands out to me. Oral iron is labeled generally ineffective. Why bypass the GI tract entirely and mandate IV iron infusions?
Remember the venous congestion we discussed earlier? The raised JVP, the hepatojugular reflux?
Get backwards plumbing back up.
Exactly. That right-sided back pressure doesn't just engorge the liver. It backs up into the splanchnic circulation, causing severe edema in the bowel wall itself.
Wait, so the intestinal villi are literally too swollen to absorb the oral iron molecules?
Precisely. You can prescribe high-dose oral iron pills for months, and it simply passes through unabsorbed. It just causes GI distress without ever raising the serum ferritin.
Wow.
You have to utilize IV iron to bypass the congested gut and directly feed the mitochondria in the failing myocardium.
Which just highlights how every system in the body is compromised by the central pump failure.
Yeah.
And speaking of different presentations, we have to look at HFpEF, heart failure with preserved ejection fraction.
Right, where the EF is 50% or higher.
The demographic profile shifts heavily here toward elderly, obese, hypertensive females. What is the fundamental mechanical difference occurring in the myocardium here compared to the floppy, dilated balloon of HFrEF?
In HFpEF, the left ventricle isn't weak. It's heavily hypertrophied and stiff. It's concentric remodeling.
So it's thick.
Very thick. The muscle squeezes effectively, hence the normal ejection fraction. But because the walls are so thick and rigid, the ventricle cannot relax during diastole. It's like trying to inflate a balloon made of thick leather.
Oh, that sounds difficult.
Because it won't stretch, the chamber can't fill with an adequate blood volume, and the backward pressure into the lungs is immediate.
And for decades, the entire pharmacological arsenal failed to touch HFpEF mortality until the SGLT2 inhibitors proved an outcome benefit. It really underscores how entirely different the pathophysiology is.
It's a completely different mechanical problem.
But what happens when pharmacology, no matter how advanced, reaches its absolute limit? The sheet shifts aggressively into device therapy here. Implantable cardioverter defibrillators, or ICDs, and cardiac resynchronization therapy, or CRTs.
These are the mechanical safety nets. You need them when the structural remodeling creates severe electrical instability.
Looking at the indications, an ICD is implanted when the ejection fraction drops to 35% or lower. Its primary function is the prevention of sudden cardiac death from ventricular arrhythmias.
Correct.
But a CRT is indicated for a very specific triad. EF under 35%, persistent symptoms despite optimal meds, and an LBBB, a left bundle branch block with a wide QRS complex.
The classic board question triad.
Right. If we look at their functions, an ICD operates kind of like an automotive airbag. It just sits quietly in the background, doing absolutely nothing for the patient's daily symptoms, just waiting for a catastrophic electrical crash.
Yes, waiting for VFib.
And if the heart goes into ventricular fibrillation, it deploys a massive shock to reset the system. But a CRT functions more like an orchestra conductor.
That's a brilliant way to conceptualize dyssynchrony. Walk through the LBB-BB mechanics in that analogy.
Sure. So when a patient develops a left bundle branch block, the high-speed electrical highway to the left ventricle is severed. The electrical signal has to slowly muscle its way through the myocardium instead.
As cell by cell.
Right. Consequently, the right ventricle fires first, and then a fraction of a second later, the left ventricle fires. The two sides of the heart are playing their instruments entirely out of time.
Creating a disorganized, wobbly, highly inefficient motion.
Exactly. And that mechanical dyssynchrony wastes massive amounts of kinetic energy, exacerbating the failure.
It's exhausting for the heart.
So the CRT, utilizing biventricular pacing leads, acts as the conductor. It forces the right and left ventricles to fire at the exact same millisecond, restoring the synchronized squeeze. It doesn't just prevent death, it dramatically improves the actual pumping efficiency and relieves symptoms.
Which is why a CRT can often induce reverse remodeling, actually shrinking the dilated ventricle over time.
It's amazing technology.
But we must acknowledge that even with the Fantastic Four, IV iron, and perfectly tuned biventricular pacemakers, the system is incredibly fragile. Patients can abruptly spiral into acute decompensation.
Right, stepping into the danger zone. The sheet uses the champion mnemonic to identify the acute triggers that throw a stable patient off the cliff. Acute coronary syndromes, hypertensive emergencies, arrhythmias, mechanical complications like valve ruptures, and pulmonary embolisms.
Any of those can tip the scales instantly.
When one of these hits, the patient presents in acute pulmonary edema. They're literally drowning in their own fluids. The immediate algorithm is aggressive. You sit them completely upright to pool blood in the legs, apply CPAP to physically push fluid out of the alveoli, and administer massive doses of IV furosemide and nitrates.
Standard emergency protocol.
But the protocol specifically highlights what not to do. Avoid routine morphine and avoid excess IV fluids. Let's look at the absolute worst-case scenario here, though. If the intervention fails and the patient slips into cardiogenic shock, the hemodynamics completely collapse.
That is the physiological point of no return without intensive care. Systolic blood pressure plummets below 90. The body triggers massive peripheral vasoconstriction, shunting all available blood to the brain and heart.
Leaving the extremities ice cold.
Exactly. The kidneys completely shut down, halting urine production. The hemodynamic profile shows catastrophically low cardiac output paired with astronomical systemic vascular resistance.
At that point, you're relying on central lines and pressors in the ICU. Like dobutamine to chemically whip the failing muscle to squeeze, and noramepinephrine to maintain perfusion pressure.
It's an incredibly precarious state.
It really is. Which makes the final section of this exam sheet arguably the most critical for outpatient management, the drugs to avoid list. I was genuinely stunned to see ubiquitous over-the-counter painkillers like NSAIDs, ibuprofen, naproxen on the absolute do-not-fly list for heart failure patients.
It surprises a lot of people.
It seems dangerously easy for a patient to accidentally trigger their own cardiogenic crisis just by treating a joint ache.
This is perhaps the most vital piece of patient education a clinician can provide. The toxicity of NSAIDs and heart failure is driven entirely by renal hemodynamics.
How so?
Well, in a failing heart, cardiac output is low. The kidneys sense this low flow and panic, assuming the body is bleeding out. To maintain glomerular filtration, the kidneys rely on local chemicals called prostaglandins to keep the afferent arteriole, the inflow pipe, wide open.
And NSAIDs are specifically designed to block prostaglandin synthesis.
Exactly. When a heart failure patient takes an NSAID, they instantly eliminate those protective prostaglandins. The afferent arteriole violently constricts. Glomerular filtration just tanks.
Wow.
And the kidneys respond to this perceived extreme drought by holding on to massive, dangerous amounts of sodium and water. A perfectly stable patient can be thrown into flash pulmonary edema from just a few days of over-the-counter ibuprofen.
The interconnectedness of the renal and cardiac systems is just unforgiving. The blacklist also includes non-dihydropyridine calcium channel blockers like verapamil and diltiazem.
Yes, because they possess potent negative inotropic properties. They directly block the calcium channels required for myocardial contraction.
Actively weakening the squeeze of a pump that is already failing.
Exactly, which is a disaster.
And to prevent these cascades, the follow-up rules are obsessive. After initiating or altering any guideline-directed therapy, clinicians must recheck blood pressure, heart rate, creatinine, and potassium within 1 to 2 weeks.
You are constantly walking a razor's edge between optimizing cardiac output and inducing renal failure.
It is a delicate, continuous titration. Well, we have dissected a massive amount of clinical strategy today. Let's synthesize Dr. Isaful's algorithmic journey for you.
Let's do it.
First, suspect the failure based on functional symptoms and bedside congestion. Deploy the BNP as your bouncer to rule out the disease, but mandate an echocardiogram to confirm structural geometry and EF. Once confirmed, rigorously hunt down the root cause using the failure mnemonic. Do not just treat the syndrome.
Find the trigger.
Right. For HFR-EF, aggressively establish the Fantastic Four within 2 to 4 weeks to modify the disease while using diuretics strictly as the bucket to bail out symptomatic fluid. Hunt for hidden metabolic deficits like iron, utilizing 5E repletion to bypass gut edema.
Keep going.
If the electrical system fails, deploy ICDs for protection or CRTs to resynchronize the pump. And finally, educate the patient to avoid pharmacological saboteurs like NSAIDs.
When you lay it out functionally rather than just as a list of acronyms, it really reveals a masterclass in hemodynamic engineering.
It really does. And for you listening, understanding the why behind these mechanisms transforms a confusing medical chart into a logical narrative.
Yeah.
You now know exactly why a cardiologist might accept a mild bump in creatinine, or why they insist on IV iron rather than pills, or why they are obsessed with titrating beta blockers in a weak heart.
It demystifies the whole process.
Exactly. But I want to leave you with a philosophical question to ponder. We've spent this entire deep dive analyzing heart failure. But when you consider the sheer power of the Fantastic Four, biventricular pacing, and the incredible plasticity of the myocardium to undergo reverse remodeling, at what point does the term heart failure become excessively grim or even medically outdated?
That's a fascinating thought.
Right. If a patient